here lately. And so what we're going to do today is we are going to go over the bill, the Script Act that just got passed and is on its way to the governor's desk to get signed. There's a lot of questions about it, both good and bad. And so our goal here is to go over each section of it. And then we're probably going to give you a rundown of each section and then field questions because we know there's going to be a lot of questions. To start off, and Joe and Jesse and Hardy, if I miss somebody, you let me know. But to start off, we're going to just kind of list all of the people that were involved in this. And so Senator Benton Sawry was the original sponsor of this and brought it to the floor in the Senate and then went over to the House. Had some changes done into it, but Benton Sawry, Heather Ryan in the House, who is the lone pharmacist of the group, and Danny Britt, and who am I missing, Joe?
Well, we got sponsors. The primary sponsors of the bill were Benton, Sawry, and Gailey. But then there were several other sponsors that weren't considered primary that boosted the bill from the get-go and helped in all the behind the scenes negotiations. But the ones that were doing, at the table were primarily from the Senate side was primarily Sawry and Britt and Gailey.
Yeah, Britt, Sawry, and Gailey, and then Heather Ryan in the House was a key member that helped with that. And so, Absolutely. as we go through this process, it's been a lot of learning. It's been a lot of educating. It's been a lot of dealing with the whole legislation process, which is, and keep in mind that this isn't, you may hear me reference this like this is we or our. That's not the BHAC group I'm talking about. These bills were never ours. They were the legislators to start with. And so these legislators brought this forward and worked on this tirelessly to get it across the finish line. And we helped in that measure, but we did not, they were not our bills. And so it's their baby, it's what they do, and they are very passionate about it. They love pharmacy and they want to do everything they can. So in the legislative process, before we start going through it as well, because you're going to hear people that really love this bill and scream about it, and you're going to hear people that don't like the bill for whatever reason. And one of our lobbyists at the very beginning was like, look, the legislative process this is how this works. You're not going to get everything you want in one bill. And we started this PHAC group not so that we could do a one flash in the pan kind of legislative blitz. This is something that we know that we're going to be working on for years to come. This is a yearly thing. This is a long fight. The PBM's really, really, really good at legislative affairs, and they know how to tweak it. And so everything that we are doing, this is just the start of it, right? This is a huge bill that is going forward that we haven't been able to get through in North Carolina for quite some time. So there's been a lot of ground made up, but there's a lot of work left to do. We know that, and we're in it for the long haul. So just keep that in mind as we move forward. As we go through the different sections, make sure that you write things down that you have questions on. Some of the things are really difficult to understand if you read through the bill. We're going to do our best, and to be quite honest with you, we're still going through the bill completely, and getting comments from other people and policy experts to make sure that we understand it well enough and that we're going to do what we need to do. So stay tuned for that. Okay, so with that being said, we'll go to the first slide.
Hey, Brent, can I interrupt you for one sec?
Please, anytime.
Hey, everybody, it's Jesse. So, we've of course closely been following both bills for this whole time. And last week there was a flurry of activity that everyone probably knows. So a lot of the House bill was added to the Senate bill, which we were excited about. And then the Senate didn't agree, which we didn't send out a newsletter update last Sunday. Hopefully you guys all got that. But kind of went back and forth, and the conferees were appointed, and basically the point was for them to meet and come up with kind of a resolution and an agreement between the two bills. And so it's been a fury of activity. The bill just became publicly available yesterday. And so we were up late till after like 11 o'clock last night trying to go through it. So just be patient with us. We did try to put together the information as best as we could for today. I mean, Brentwood and I were on the phone until literally 3 o'clock trying to get this together. So we are going to try to get you all the information as accurately as possible, but just be patient with us on it.
Yeah, we're still learning as well. We had a lot of input on the bill, but there's a lot of things that came out that were just as much of a surprise to us as they were for anybody else. And so that's just part of it. And so we're learning as we go.
And as of right now, the General Counsel of the General Assembly has not yet released their opinions of everything. So if you don't know how all this works, these bills, when they're written, and it's still going to the governor's desk and he'll be signing it, but there's attorneys on staff that will be interpreting, pieces of the bill to help explain what the intentions are of it. And to my knowledge, as of right now, that has not been published yet. Earlier versions have been published, but the bill has changed so much that as of right now, what came out of the conference committee, that report has not been made public. So there are some things that, well, that could mean this or that could mean that. To reiterate what they're both saying, none of us are attorneys. We're pharmacists just like you, and we're still trying to wrap our heads completely around that. And then we hope to have as much input as possible in how that interpretation works as possible.
And as you get done with that, if you don't get a question answered on here, and there'll be some people, this is being recorded, I believe, so I'll say this for them as well. If there's a question that comes up that you didn't get to ask or you would like to ask, please email us. Like that's what we're trying to do. We want to be the umbrella that funnels all these questions so that we can help you out. We may not know the answer to it. I can't guarantee you that, but we will try. Okay. All right. So I'll take the first part here. So pharmacy of choice modification. So this just goes into the fact that PBMs can't funnel patients to their own pharmacies or be able to force them in any way, shape, or form to mail order or change their copays to benefit going to one of their affiliated stores. And so you'll see some things in here that you can read through and see. But one of the things that were mentioned and debated on was pharmacy desert and independent pharmacies. So those are definitions within this section that we were working on very closely right up until the very end, talking with the legislators, meeting with the legislators, trying to define that. And it changed even from where we had talked with them right before the bill had come out. And so you can see it. A pharmacy desert is either one of the following areas: an urban community or neighborhood without a pharmacy within a 2-mile radius. And they define an urban neighborhood there, densely developed area with at least 5,000 residents or 2,000 housing units. A rural community without a pharmacy within a 15-mile radius of any point in the community. So rural being an open county or settlement with fewer than 5,000 residents or 2,000 housing units. And so for those of you who don't know, there are rural contracts out there that are specific for pharmacies that are in rural areas. And so part of that was to make sure that they were taken care of and that PBMs didn't discriminate against pharmacies in rural areas because they need that network adequacy to be able to do that. The one thing that's not in here that you don't see that we left out of our slide that Jesse just let me know is the definition of an independent pharmacy. So the way that they defined independent pharmacy was a group of 10 pharmacies or less would be an independent pharmacy under the definition of this bill. There are pharmacies out there that are independents that have more than that, and we are well aware of that, and we fought tooth and nail to change that. We are still unaware of why it got to 10 and what that means, but that's also something that we are working on, and the legislators know that we want to work on that. So if you're in one of those pharmacies, please don't despair. We are going to be working on that moving forward as well. Let's see. So pharmacy of choice, that kind of gives there. Am I missing anything there, guys? Does anybody have any questions?
I want to elaborate just real quick.
I mean, I was just gonna
go ahead, Jesse.
Okay. I mean, I was just gonna say, I mean, the independent pharmacy definition, it was 5, which we fought really hard against. I mean, it's great they increased it to 10, but like Brent said, we don't know exactly why they capped it there. We do know that most people were fighting to get it increased. And so we're not sure where that limit came from, but we are going to continue to fight that. Joe, go ahead.
So good point. So what I was going to talk about was the rural versus urban. So in my brain, I think of, all right, well, my store is rural. So, but you know, technically speaking, there are only 2 counties in the state of North Carolina that meet this criteria for 5,000 or less, and that's Tyrell and Hyde. Those are the only counties that have less than 5,000 people. Only Tyrell has less than 2,000 housing units. Therefore, even if you live in the middle of nowhere, you are an urban store according to this definition. So just don't despair if you're like, well, I'm in a 10 store or I'm in a 12 store group, and all our stores are out in the country, but and so I'm worried about that. I'm within 15 miles in my rural area. According to this definition, if you're in a group greater than 10, it's pretty likely that you're in an urban area because your county has more than 5,000 people. And so if you're at least 2 miles away, at least some of your stores would likely be included in these price protections that would come from the pharmacy deserts. So I think this was I don't know if this was intentional, but there's definitely a benefit there, increasing the number of stores that would be applicable to deserts.
And you'll see why these definitions, we're not really telling you why these definitions are important right here, but the way they define them is further down the bill as to where they apply and where they don't. So this entire bill doesn't just apply to independent pharmacy. Parts of the bill are for every pharmacy in North Carolina. Some of them are more defined for deserts versus independents and stuff. So we'll go through that. Okay, next slide. So this part was, this was a big sticking part for the beginning of the bill. Pharmacy Services Administration, so PSAOs, probably everybody on this call is independent pharmacy, has a PSAO. And quite frankly, I think the PBMs like to try and hang a lot of things on PSAOs. There was a lot of education that went on in this piece for independent pharmacies saying, look, PSAOs really, they without them, we don't have a lot of contracting help. We don't have, a lot of negotiating power. And so we really need them. The biggest part of it was that it did have a fiduciary responsibility in this for PSAOs, meaning that a pharmacy could hold them financially responsible for a bad contract that they held. And PSAOs really didn't like that. That put too much risk on them. For the best PSAOs, they were just a pass through, that you pay them a fee and they manage your contracts and collect your money and put it in your bank account. And so they don't have a lot of a dog in that fight financially, for most of them. And so we whittled it down to what you see here, which is, we think is pretty good. So, and I say we, again, that is the legislators, not PHAC. PSAOs must be licensed by the Department of Insurance. They require disclosures of ownership, control, and material changes. So if a PSAO is owned by a wholesaler in any way, shape, or form, they must disclose that, is what that means. Must provide contract terms of pharmacies. This is one of the things that we're waiting to see kind of what that looks like, because right now, if you call your PSAO, they tell you they can't give you the contract term for a lot of your PBM contracts. So we're hoping that will allow us to get some of that through, because it would be really nice to see what contracts we have. Prohibits price discrimination or drug purchasing requirements, which really isn't something that PSAOs do. Communication responsibilities during appeals. Also, most PSAOs aren't involved in appeals or audits. That's really a PBM to pharmacy specific area, so don't be confused about that. And then penalty for violations, including daily fines, if they don't do the reporting that they're supposed to do. So pretty straightforward piece there. Again, a lot of people are confused as to why that's in there. But I think that's part of the political game, trying to make everybody a little bit happy. So that's that. All right. Part 3 is the PBM transparency, fair reimbursement, and fiduciary duties. So the objective here is to increase accountability of PBMs and ensure fair reimbursements to pharmacies. So this is a big part here, and really, I'm sure there's going to be a lot of discussion about this part because really, this is what got the PBMs all in an uproar yesterday or the day before when they were going through all of this stuff with bills. It is this part in particular. So as you can see, they must submit annual transparency reports. So this goes to the DOI. So these are including rebates, spread pricing, affiliated pharmacies. So all of this reporting, which hasn't been done before, now has to be done by the PBMs. So they can no longer cheat people out and hide their spread pricing, hide their rebates. All of that stuff has to be reported. They cannot require independent pharmacies or pharmacies in a pharmacy desert to dispense medication when being reimbursed below cost. So we will have to stick with this point for a little bit, and Joe and Jesse, I'll let you chime in on it. But basically, the way that we read it is that it's not saying they cannot reimburse you below cost. It's just saying that they cannot require you to fill anything when it is reimbursed below cost. So in other words, it gives you a refusal to fill on that particular item. And it also gives them fiduciary duties to the insurer. So they have to, again, a financial, if you were caught and felt like you had to, if they were requiring you to dispense an item like they do now, and a lot of pharmacists hide in fear of telling a person they can't get their medication because they feel like the plan is going to call them and cut their contract out or fine them or do whatever that's in the contract. Now you have some ground to stand on, and if they require you in any way, shape, or form to accept that, then you can thereby turn around and say, actually, I don't, and this is enforceable by the Attorney General's office. So, Jesse, Joe, chime in whenever you like.
So to add to this, one of the most impactful parts of this bill is that not only is the North Carolina Department of Insurance going to be, involved and included in the enforcement and the auditing of PBMs, but Chapter 75 is a reference to the Attorney General's ability to have complete purview and prosecutory actions, be able to take prosecutory actions against these entities. If you've been in this business for at least a decade, you've seen some legislation passed down that you got excited about, and then you found out later on that nothing was ever done with the legislation. It wasn't enforced. Well, bringing in the Attorney General into this bill and giving him purview into all of the actions of PBMs has not been done in North Carolina. And this is a way that when you draft legislation and you want to be 100% sure that it is enforced, this is how it's done. When PHAC first got involved with this, that was one of our biggest concerns, is we were going to spend a great deal of time working on legislation that we were afraid would not be enforced. And it wasn't our idea. It was actually the idea of Senator Sawry, that he wanted Chapter 75 included, and the powers that be in the Senate themselves recommended this. And so that's why this is going to be so different. Regarding a pharmacy's ability to not dispense a medication at a loss, I have talked with some folks from PSAOs today, and I sent them copies of the bill, and I sent them the specific sections that revolved around reimbursement, and I was asking for opinions. And the first question was, how is this enforceable? When I said Attorney General, they were very excited. They said, well, then your bill has teeth. The next thing that they pointed out was this bill is only going to work if pharmacists follow the bill. So if you in your pharmacy, if you have plans that are applicable to this bill and you continue to fill those medications at a loss and you don't respond to this legislation at all, well, then all of the work that went into this was for nothing. Because PBMs have a service to the client that's hired them to ensure that the medications are being provided to their patient population. If every pharmacy continues to fill them even at a loss, well, then nothing's going to be upset and everybody's going to keep carrying on. But when employees can't get their prescriptions filled at their local pharmacy because the loss is too significant to the pharmacy, and that information keeps reported back, it will start to have the impact that we're looking for. So this legislation is only as good as the action that you all take moving forward after October 1. So, thank you.
Okay. Next slide. So part 4 is all about anti-steering and network adequacy. And so the purpose of this part was to prevent PBMs from steering patients to affiliated pharmacies and to ensure adequate pharmacy access. And so parts of the provisions in there, they can't penalize pharmacists for charging shipping fees if those are disclosed. Networks must comply with Medicare access standards, meaning there must be a large enough, correct me if I'm wrong, but a large enough pharmacy network to maintain the adequacy of that network. And so they can't, just ship everything to mail order within a certain thing. You have to be able to have enough of pharmacies within that area to meet those standards. For those that with specialty pharmacies, they cannot require excessive specialty pharmacy accreditations. And what that means is some of the PBMs were pushing people to go through certain different accreditation areas. And I don't have a specialty pharmacy, but that was expensive and that was time consuming and irritating for a lot of specialty pharmacies and their ability to be able to gain access into the network. And so they defined it much more clearly within that. And they must allow fair participation in networks and disclose contract terms to pharmacies. And so those are all parts to allow, better network adequacy and make sure that another part of the bill to make sure that they're not steering patients to their own pharmacies. Am I missing anything there?
I don't think so.
Okay. Jesse, you want to do audit protections?
Sure. So the audit protections for anybody that has the bills, it's kind of pulled up. It's kind of long. It starts on page 11. And so this part actually was strengthened. So the audit piece was different between the House and the Senate version of the bill. And so last week, Representative Ryan, part of her additions to the Senate bill was to strengthen the audit part of the Senate bill. And her edits to that did remain in this final version. So like I said, the section is very long. You can reference it and read through it. One of the main things that she changed from the Senate version of the bill is the first part here. So no more than 50 fills or 0.1% of total number of scripts filled through that PBM for the year. So that was strengthened from the Senate version. The Senate version previously was just 100 fills, period. PBMs do have to provide at least 14 days notice of an on-site. And then it does prohibit recruitment of payment without appeals or fraud. And then a couple other things listed here. So like I said, it is a pretty long section. I think one of the biggest pieces is the beginning part, just limiting the volume that they can actually audit.
And audits are more annoying than they are anything. They can be costly depending on it, but this was, they worked on this a lot. And we had a lot of questions coming from them about this, but it was a good provision they put in there just to add a little bit more protection.
And I think, Ritesh, I don't know if you have your hand raised.
I do.
Okay, go for it.
Hey, sorry, I have a question and I apologize. I was late, so you may have answered this question. I'm sorry if you have to repeat it, but I know the bill also talked about contracts after October 2025. So are we thinking that either at renewal that this will, so our current contracts that we have today are not eligible for this bill, right? So like we have to more than likely renew. I'm sure there's renewal cycles. So, is it when we, do the recreditation or any of the stuff that we do for the payer? that will then bring them in the fold of the bill, or any thoughts on that, or any particular reasons why that was put in there?
You want to say that?
Ritesh, are you talking about the part on page 11?
I don't know if it was audits, but in general, I think it talked about there's eligibility of this bill, and it basically said any contract signed by a pharmacy with the payer. It was after October 2025. I can't remember if it was in the transparency or on when under reimbursement side, somewhere between the first few pages there, it did have that. And I wish I had the bill in front of me, but it talked about, and we can go back and answer this question via email in the future if we need more opinions. But I just, like Joe talked about earlier, how we want teeth, and the prior bills didn't have as much, or any teeth at all. We want to make sure that if we as owners need to do something with our contracts and have new contracts with these payers to make them eligible, you know, for this bill, then we just need to make sure that we're thinking about that. I don't know if it's all parts of the bill or that one particular section
What
of the
you're
bill, but there.
Yeah,
What you're
I do
referring
see it
to
in a
is at
couple
the
of spots.
section, it's at the bottom, section 1.2. It says the part becomes active October 1st, 2025 and applies to insurance contracts entered into or amended on or after that date is what he's
Right.
saying.
Right. Yeah. Yeah. That was it. I just want to make sure that we're thinking about that and see how that makes a difference in what we're going to do in the future, of course.
Of
Because
when
they
we
may
go
just raise it.
live
You
with
you
our
may you may
actions.
go back and lodge a complaint, or refuse the script, and the payer may come back and say, hey, look, this bill, this is not, this doesn't matter because this pharmacy was in a contract with us before October 2025, so I don't have to follow that.
So that would probably, if you were direct, I guess it would be post amendment after that date. And then if you were with a PSAO, then that would really
Right.
be a question for them and the particular plans that are going to be applicable to this piece of
Yeah.
legislation.
Yeah. And thank you for doing this, by the way, guys. Appreciate it.
And thanks for being here.
Thanks, Ritesh. Okay, next piece, PBM affiliate regulation. So this piece, I mean, the main part here really is that just PBMs cannot reimburse their own pharmacies more than they reimburse other pharmacies. So that's the main part of this bill that we're hoping will have a good impact for a lot of the pharmacies in the state. And I think this one is, Joe, Brent, correct me if I'm wrong, but this one is not limited to their independent pharmacy definition, correct?
That's correct. Yeah, this is for
Yeah,
all
this
pharmacies in the state. Yeah, this
correct.
covers all pharmacies in the state, and it's, this is what we refer to as the Fair Nation Clause, where they can't reimburse their affiliated pharmacies, obviously more than they reimburse ours. And so there are other states around, I think it was Mississippi, most recently, that did this a year or so ago. And what they did is they had the Board of Pharmacy. In our case, it's the Department of Insurance and the AG that would be responsible for parts of this. I think maybe most of this part is associated with the AG, but if a complaint is filed, then they have to do the digging, and if they can ask, and once that happens, then they can ask for anything they want to from that PBM to justify where they're getting their pharmacies paid from. And when Mississippi did this, they did it a little bit differently in that they had the Board of Pharmacy um, push the PBMs to give them so that was in their requirement of the bill, is their Board of Pharmacy had to do it. And then when they did, what they found out is some of the PBMs were reimbursing up to like 175% more for their affiliated pharmacies than they were reimbursing independents. And so we know that goes on, and that's one of the ways that they're driving up their profit margins is by reimbursing their pharmacies more. And so this bill takes all of that out. And if it does happen, then you can see Article 63 and enforcement of Chapter 75, that goes back to the AG. So we have a lot, this is kind of creates a floor for our reimbursement costs, which is much different than what we have right now. Okay. Next. So the consumer cost sharing and transparency, that was to ensure patients receive the benefit of manufacturer rebates at the point of sale. So making sure that they pass through anything that they have from a rebates perspective from a PBM at the point of sale. This one more deals with a patient and overall cost of the medication more so than the pharmacy. So the cost sharing, which is between the PBM and the pharmacy and the patient, must reflect 90% of the rebates received. Joe, you had a good explanation of that, or a good example of what that looks like. You want to share that?
Yeah, so basically think about it like this. If the drug cost $1,000, let's say, and the manufacturer is going to provide a 10% rebate back to the PBM if that drug is placed on their formulary. We know these things happen. Drug manufacturers don't like PBMs in a lot of cases any more than we do because they're forced to play these games. So, so let's say they've got that 10%. That brings the price of the drug down to the PBM out of the gates to 900. Well, if the patients and all of these benefits are supposed to be passed along to the patient. So let's say that the patient has co-insurance instead of co-pay. Well, then theoretically, the price of the drug in the eyes of the patient's copay could be as low as 900. This bill says that they have to apply at least 90%. So in other words, instead of it taking $100 off the price of the drug, which was 10% of 1,000, it would $100 off the 1,000. I'm sorry. It would take 90% of that $100. So it would take $90 off the price of the drug, and the patient's copay would be calculated off the 910. Now, there's been some questioning about this because is the patient's copay based on the total price paid in the pharmacy, and would this potentially impact how much the pharmacy is paid? And if you read in through your third-party contracts, there is no reference to manufacturer rebates back into PBMs because this is not something that PBMs really want to make public knowledge. So your contracts will still be based on AWP, WAC, MAC pricing, favored nation pricing, et cetera. But this is one of the ways that PBMs have been increasing drug prices or maintaining higher drug prices so that they could use back-end rebates. And now they can't receive the benefit of 90% of that rebate. It must be passed down to the patient. It's no longer going to be a method of spread for them to pad their profits.
Okay, the next section was just about prescription drug transparency. So transparency of price, requiring drug manufacturers to report price increases and new drug pricing. It's pretty straightforward. I don't think there's a ton of questions associated with it, but you can see there they have to disclose 15% plus or more price increases annually. New drug prices must be reported within 3 days of market entry, and so on and so forth. So that part's pretty straightforward. Next. Pharmacy reporting requirements. So to monitor pharmacy access and trends in pharmacy opening and closure. So they really want to be able to see, how many pharmacies are opening, how many are closing, what are we looking like from a projection standpoint as pharmacy goes. And so that's what the health of overall community pharmacy is what they're looking for. And so they want the Board of Pharmacy to report the following, and it goes through and tells you what that is. So that just gives us more insight to what that looks like. All right.
Okay, so part 10 RFP changes. So this was an addition to, haven't read too much into it, but it just says specifically the bill itself says the executive administrator shall consider So it's just saying, to me, it's reading as a recommendation. So the executive administrator shall consider incorporating the following items into an RFP for a pharmacy benefits manager for the plan. So, and you can see those listed here. And I don't know, Joe, if you have any additional insight for this one, but I think it's just right now a recommendation.
Yeah, just recommendations
correct.
for that. Yeah.
Okay. And then the last piece that was added that wasn't in the original bill, nor was it in Representative Ryan's addition to last week, is actually is great for us. So it extends Medicaid's pharmacy reimbursement rates. So the current model was set to expire in June of 2026, and this bill extends that to June of 2031.
Yeah. So that was set to expire, like Jesse said, and Senator Shari had the wherewithal to say that we need to go ahead and do this so it didn't get caught up in other legislation. So kudos to him for that.
Yeah, yeah, really, really big. Unfortunately, this is how a lot of things get done in Raleigh, where things get tossed in at the end and at the bottom. And in this case, it was really to our benefit that he had the wherewithal and the forward thinking to put that in.
So
And
that is that's the end of the slides that we have prepared for today. And so I know there's a lot of folks on the call, so we'd be happy to take questions. If you want to unmute yourself, you're welcome to do so. But thanks everybody for hopping on. Hopefully this has been helpful.
Wes Hickman here. I was just kind of curious, anybody's reading on, I believe it was section 6 about the PBM affiliates and the HIPAA data protection and all that. Anybody's reading on that in concerns to like GoodRx claim switching? I don't know how much data gets shared between that at all, but it would seem to me that that would be maybe impacted by this in a positive way. Anybody else have any thoughts about that?
I hadn't thought about it, but now that you say it, Wes, that there could be implications as far as them being able to share any of that data on that side. Yeah, but
it would make sense.
yeah, but I hadn't considered it, but that'd be a good thought if that is the case.
Mm-hmm.
Yeah, thanks, Wes. And if anybody has the bill pulled up, it looks like it's on page 16.
They can't sell.
Oh, and make sure if you're looking at the bill, because this has caused a little bit of confusion, when you pull up the Senate page where Bill 479 lives, typically you would look at the not addition, but the addition. So in this case, do not look at addition 6. You have to actually drop down the page just a little bit, and you have to look into the history, and you will pull from the conference report document. So version 6 is as it looked after it left the House. And so you're going to want to drop down into the conference report to see it there to get the most current version. There you are. So going down through your history, no, that's the top one. So go to the bottom. And so yours looks different than mine.
I think if you click the quorum sometimes or one of the other ones, it'll show it somewhere in there.
So mine, here, I'm gonna share my screen if that's all right. Let's see. So if you can see my screen, here on the page itself, you see this conference report here, this substitute report, and this is where the most current version of the bill lives. And you can tell because here at the bottom you'll see this substitute in it. So make sure that your bill has this in it to be sure that you're sharing or you're viewing the most current version.
Any other
And
questions?
well, I just now pulled up the chat. There's a bunch of questions in the chat.
Okay.
Can you email the slide deck to attendees? Yes. Um, Someone says they noticed the last version of the bill, the rural definition referenced 5,000 in one location and 20,000 in another. I think that was before we covered that though. For the 15-mile radius section, PBMs often use 15 miles based on how the crow flies when qualifying stores for rural rates. Is that how it is interpreted, or is it 15 miles by drive distance?
Well, as pointed out earlier, Thomas, even though you do live in Scotland Neck, which is the most rural place in the world, if you've ever been there, you are in a county that has more than 5,000 people. So technically speaking, per that definition, you live in an urban area, sir. From the way that we read it. Okay. Now we're not legal scholars, but
So then it's the two mile rule.
Yes, sir.
All right, I like that.
I figured you would. Yes, sir. Thanks for being here. Yeah. Part 1C4. Jonathan, where are you going with that, buddy? Oh, he's asking about the 20,000.
Did we clarify that, Joe, when you were covering that?
I'm jumping back into it. I do remember that there was a reference to 20,000. So this is a different section. And Brent and I have talked this through several times. The question, what he's asking about, it says, I'll lead off with the header. The short answer to this is we're not 100% sure. These are prohibitions. It says an insurer shall not do any of the following. And 4 says impose a monetary advantage or penalty under a health benefit plan that would affect an insured's choice of pharmacy, including a higher copayment, a reduction in reimbursement for services, or the promotion of one contract provider over another by these methods. And then it says prohibitions on this imposition of a monetary advantage shall not apply to monetary advantages imposed upon a pharmacy located in a pharmacy desert or a county with a population of fewer than 20,000. I am not a lawyer, and I have read this thing 100 times. And we feel like it's something, and again, this is an assumption, so don't hold us to this and don't hold me to this. We think it's something to the effect of they're still allowed to use rural contracting where they're able to pay others more, but we're not 100% on that. And so we're really looking forward to the legal crew from the General Assembly hopefully further explaining this. Melanie, if you know the answer to that, please jump in.
This is more conspiracy theory idea here.
All right, go ahead.
I do agree that I'm not a lawyer either, but
right.
The way that I've seen this type of language used in the past is to leave the door open to allow mail order to service rural areas because they can't get the right retail rural contracts in place. And so I would suspect that they wanted that provision to allow one copay for 90-day mail order savings to service rural areas. But that's my gut reaction to that. So
potentially, yes, ma'am. Thank you. There are 17 counties in North Carolina that have fewer than 20,000 people. We've already been looking at all the census data, trying to figure out what the impact of some of these numbers were. A lot of rural eastern North Carolina, and then a handful of smaller counties over in the western part of the state.
Okay. Thanks, guys. Sorry, is there more on that, Joe?
No, ma'am. All good.
Okay. I'm gonna just keep going through the questions in the chat. Let's see. The next one, with PBMs going more and more direct, not through PSAOs, does this nullify the whole bill? Or what is the expected impact?
Are you, well, Greg, I mean, this bill is applicable to all contracts, PSAO and direct. I think it would just come down to when your contract terms are negotiated for the sections that would be applicable to contracts that would occur after October. So I don't feel like they do discuss the PSAOs in it, but since this is all pharmacies in the state, they're even
Right.
referring to chain pharmacies. This is not a PSAO specific legislation.
Correct. That's the way I would read it too. Um,
All right. The next comment, we just need to make sure how the drug is defined since these people have their own NDC sometimes as well.
They refer to GCN in the legislation. So as long as your NDC is applicable to a legitimate GCN, it would be included.
And then this
GCN stands for
question,
generic code number. Every lisinopril 10 in a bottle has the same GCN. Every levothyroxine 100 microgram in a bottle has the same. There might be a different one if it's blister packed, but that's how GCN works. Pioneer would call them equivalents if you were on Pioneer. That's how they determine it.
and then this question, which I think is probably on a lot of folks' mind, how do you know if we are being paid the same as their affiliates? So that's kind of touching on the equal nation clause that's going to be under the purview of the Attorney General to enforce. So, Joe, I don't know if you want to touch on that one.
Yes, so I've had some conversations about this, and Melanie, I know you're here, and so I'd love to hear your input on this too. I've had conversations with other representatives of PSAOs, and they did say that this is the one place where we need to stay involved as we can. We being pharmacists here in North Carolina, and make sure that this particular piece of the puzzle is put together as complete as possible. Um, Other states have used this type of legislation, and so there are examples. Mel, if I'm wrong, didn't Oklahoma do this quite some time ago?
Yes, but we did it at the NDC level because of pricing variability across NDCs within a GCN. And
Mhm.
that's why I need to reread that section of the bill to
Mhm.
see exactly how tight that is, because otherwise the PBM is going to be able to set a price that represents every NDC inside the GCN. And if you happen to be tied to a wholesaler or buying group that uses a different NDC at a higher price, you're going to be out of luck. So that's why I want to pay real close attention to that and see if there's any wiggle room there.
Right, right. So that the point is just making sure to echo that and what we've already been told is just confirming that the methodology that is established to assess what they are paying and how they're paying it, making sure that we pick up any sort of back end movements that they have, we can bring all that to light, just like what was done in Mississippi. You all remember that report? It went across I mean, every group I was a part of, every text thread I was on, it was being discussed. And I think it's one of the things that lit the fire under so many this legislative session to get so much accomplished across the country. So hopefully we'll see another fire just like that here in North Carolina.
Mm-hmm.
All right. Thanks, guys. The next question, did the proposed committee substitute calling for NADAC plus dispensing fee? So yes, the PCS, which for those of you not familiar with that name and acronym, that was what Representative Ryan added to the bill last week. She did add several pieces of the House bill, as we mentioned in the beginning. And yes, one of them was NADAC plus the dispensing fee. So she had added that in her version. But as a part of the negotiations, that was taken back out, which I know a lot of people are bummed about that. But we were told all along that the Senate is not going to pass that NADAC plus, unfortunately, at this point. And I don't know if Joe or Brent want to add anything on that one, but the next piece, you said at the beginning, we didn't get everything we want in the first bill. So with that in mind, and based on what is in Senate Bill 479, what are going to be the goals and desires for legislative action in 2026?
I mean, when our first PHAC meeting that we had at the beginning of this year, and Brent's already said this, so I'm just going to be echoing what he said. We knew that we weren't going to be setting out to just help influence one piece of legislation or one session. The idea is to grow involvement of pharmacists across the country, play an active role in the political process, strengthen relationships between pharmacists and their representation, so that we can have a voice. Do we have a structured game plan of the next style of bill or how we're going to change the next thing? No. But what we feel like this bill is going to do, there's a lot of initiatives for transparency in this bill. There's quarterly reporting back into the client by the PBM of the utilization of all spread pricing. There is the same reporting for spread pricing to the DOI and what these PBMs are doing. We're going to be able to audit and see what they're paying themselves as compared to pharmacies. There's going to be our ability to refuse to fill. We're going to be bringing a lot more attention in a legally sound environment to the PBM landscape. We're going to be able to go back to the AG and say, hey, what'd you find? What's really going on? Let's do something about it. So next year, when we're pushing for a different initiative or a different methodology of payment, or we're educating representation, we can go to them with reporting that shows that, yes, PBMs can do more and you can keep the cost of healthcare down, because you're going to be able to eliminate all of these things that we've all known are happening for years as pharmacists, but now we have the actual proof to do it. Unfortunately, our General Assembly did not have the appetite for as aggressive a stance in this year's session, but now they're going to have fodder for the cannon for next year. They're going to have the information. We're not going away. We're going to keep them informed. We're going to have discussions about what's really going on in the global environment of pharmacy healthcare. So I think this is just the first step in a long process of getting us where we need to be.
And it is, I'll echo that. I mean, it is quite a long process, right? And so a lot of these legislators, you have to remember that they're dealing with hundreds of bills all the time, and they're getting people coming in there from every direction, and they don't know which ones to trust, who to trust, what not to trust. Are they telling me the truth? Is this actual? Can they back this up? And so, developing these relationships has been huge and a huge, long part of the process. And so, as we further develop these relationships, I've sat down with more senators and representatives this year than I can even imagine that I would have. And so, and getting in front of them and talking to them, because they are real people, and they go through everything that you do on a daily basis. But it's frustrating and it's difficult. But developing those relationships so that we can get in front of them and they trust everything that we are saying has been a large part of what we're doing. And so we know that this, again, is just the starting point of it. We want to get better pricing and better definitions of a floor. We want to get more details on spread pricing and enforcement on that. All of these are going to be, big key points. We want to fix some of these things in the bill that we have, and put that in future legislation. And so that's all going to be part of it. And we know that. So, like Joe said, we don't have a complete plan put together on that, but there's a lot to choose from, and we've got it front and center for it.
Yeah, and I think I actually had another presentation this morning on PBMs, and my senator was there, and he asked, what my thoughts were on the bill, which I know there's a lot of questions for you guys on the call. And, I told him I think it's a great starting point. It's giving us a lot more than we currently have, but there is still work to do. And so, I just wanted to make sure that he knew that I'm not done bugging him about PBM reform, that we're not done with this one bill. We're going to keep coming back to it. And he even mentioned one point during the presentation, just the volume of PBM lobbyists and he said really good PBM lobbyists that are visiting them in the state capitol every day. So it's going to be ongoing. We're going to keep pushing for more. And I know we're nearing the end of time. There are a ton of additional questions we haven't yet gotten to. So I don't know. I mean, I can keep going through a couple more if you guys want, or we can maybe talk about scheduling another call next week.
Can we address the reimbursement methodology real quick?
I don't think I've gotten to that one.
Yeah, there's a question at the bottom about who was it that blocked
Okay.
NADAC. The people that blocked NADAC, well, there was a version of the bill where NADAC was brought in without a specified dispensing fee, and PCMA said that they thought it was a great idea. Okay, so it wasn't that anybody was against NADAC. They were against a dispensing fee, a structured dispensing fee, and they used the dispensing fee and lobbied against it and called it a pharmacy tax. And everybody hates the word tax in Raleigh and everywhere else in the state. And so that's why that was so effective for them in helping to suppress NADAC plus a flat dispensing fee. If the bill had gone through with NADAC without a structured dispensing fee, you could have gotten paid your cost or below your cost for that matter, depending on where you buy your drugs, plus nothing, plus 20 cents, plus a penny. And you would have been far worse off than where you are today. So it's not really NADAC that's an issue. The issue comes from these dispensing fees. Now, to add to that, for those of you that follow politics at the federal level, the president has his big, beautiful bill that had a lot of PBM reform that was in it, and all of the PBM reform has now been removed from that bill, and the only thing that was left in it was mandatory NADAC reporting for all pharmacies associated with Medicaid, I believe is how it's written. But basically, they're going to pull invoices from every pharmacy in the country. Okay. So, what could potentially happen, and what has happened twice in the past 2 years, is that when more pharmacies and all of your big chains, your groceries, your national chains, when all of them drop their unrebated invoice prices into the Myers and Stauffer database to create the new NADAC, NADAC dropped between 17 and 19%, depending on which episode that you look at. So I do wish that we did have a transparent, flat, fixed type environment. But right now, I'm personally terrified of NADAC because if that holds true and stays in the big, beautiful bill and everyone, has to report, it's mandatory reporting, and NADAC drops by 25%, if you do not have a substantial dispensing fee, your margins will be far lower than anything you're being paid right now as a whole. So number one, speak to your national representation, your U.S. congressman about you don't want mandatory NADAC reporting for all pharmacies. That's number one. And number two, keep your eye on that ball anytime NADAC is being discussed. There are several other methodologies that would be much more fair to us as independents versus NADAC as a whole. So just don't get too hooked up on the buzzword NADAC, especially in the current environment.
So Joe, quick follow-up to that. So all chain stores who get generic drugs considerably cheaper than we do are forced to contribute to the NADAC database, correct?
In the big, beautiful bill, they will be.
Yes.
They will be. Okay. Yeah. So that's going to be a real problem. You're right. Thank you.
Yes, sir.
And sometimes people that like living in Seattle, I think there was one big discrepancy where all of a sudden NADAC was much cheaper there. So they took those numbers and, this is almost a decade ago, but it took those numbers and, even for our own PBM, we saw the huge skew on NADAC there where we had to go back and adjust a bunch of pharmacies to pay them more because it wasn't true for the cost that we had.
So if you wanted to educate yourself, there's another payment methodology called PAC. And so you have PAC high, PAC low, PAC mid. And Melanie could probably talk at length about this for hours if we allowed her to. That those are more compartmentalized to look more like specific areas of the industry. There's also NADAC plus plus. You'll hear about those. So there's a lot of different methodologies of payments that can be used that are still transparent. But our issue is trying to educate every member of the General Assembly so that they fully understand our world. When, to be honest with you, 80% of pharmacies don't understand our payment methodologies and our reimbursement models. So imagine trying to explain to a pig farmer that has been elected to the Senate about NADAC and how pricing works and how rebates work and all of that, trying to get them to a place where they're comfortable to support a piece of legislation. So it's tough, And we could use everybody's help in that as we keep moving forward and progressing and trying to improve our situations.
Yeah, and so Joel from TPA just dropped a link in the chat. If everybody can click on that, it's one of their campaigns that they make it super easy. So if you haven't already done this, I think they sent out an email yesterday, maybe today too. If everybody can click on that, it's one of those pre-populated emails. You just put in your address and it'll send out an email to your federal representatives because we need to get this addressed.
Thanks, Joe.
Absolutely.
So I know we're a few minutes over, and like I said, there are still questions. We didn't get to everything. But we did record this. We'll send out the slides, and like I said, we'd be happy to set up another call if that might be helpful for more discussion, maybe sometime next week. But is there anyone that has a burning question that wants to answer it before we wrap up today? All right. Well, thanks everybody so much for joining. Sorry it was so last minute, but like I said, we just got the bill in hand yesterday, so we were kind of scrambling to get everything together and put together this session for you guys today. But hopefully it was helpful, and we'll keep fighting the good fight.
Thank you.
And thanks again to Jennifer from NCAP for helping to get this set up last minute. Really appreciate it.
Oh, no problem. Thank you, Jesse.
Thanks, everyone.
Thanks, guys.
Thank you.